Hi there. If you're a nursing student still in nursing school, this is my nursing school deep dive series wherein I talk about any contents related to nursing to help you pass your nursing school. Now, today in this video, we're going to be talking about hypokalemia. If you only remember that hypokalemia means low potassium, you are missing the big part that usually shows up on nursing exams because your instructors, that's right, can test this as a lab question, an ECG question, or a medication question, as well as a patient safety question. So let's connect the pathophysiology, the signs and symptoms, the nursing priorities, the treatment, and a couple of exam traps. We'll start with what you should recognize first and why those things happen. Hypokalemia means that the potassium is going to be below 3.5. And when potassium becomes low, it can affect the cardiac, it can affect the GI tract or the gastrointestinal system. It can also affect the skeletal muscles as well as respiratory muscles. So let's start by recognizing the cues. So I've said it earlier, the potassium, let me find a better color here, of less than 3.5 is considered hypokalemia. So 3.5 to usually 5.0 is considered the normal range, depending on the hospital and the textbook your instructor is using. So now let's look at the cardiovascular findings. Okay, so the patient may have potentially a weak, irregular pulse, and if the hypokalemia is really bad, in some situation, dysrhythmia can occur. Now, let's look at the muscles, the skeletal muscles, right? You may see muscle weakness, you may see leg cramps, and you also may see decrease in reflexes. Now, the gastrointestinal tract is also affected because it's slowing everything down. When the GI tract is slowing down, that can lead to constipation, abdominal distension, decreased bowel sounds, or even in worst case scenario, you can end up with paralytic ileus. And finally, if the muscle weakness becomes severe, it can affect the respiratory muscles. When that respiratory muscle is affected, then it can cause some sort of shallow respirations. So remember this, when these respiratory muscles are already affected, guess what? Your priority is airway. Okay? That would be your priority. So those are the cues you may see. Now, let's analyze them because recognizing hypokalemia is only the first part. You also need to understand why the potassium become low or why are they dropping and why these symptoms are occurring. So this is where we're going to start looking at analyzing the cues. So this is where I want to begin with the potassium losses, this section or this bullet point over here. So the reason why there is hypokalemia is because of potassium losses. So what are the potential culprit in there or causes in there, right? Diuretics can increase renal potassium loss. Potassium can also be lost through vomiting, diarrhea, or prolonged nasogastric suctioning. So again, this is where continuous nasogastric suctioning can produce hypokalemia. Potassium can also shift into the cells from the bloodstream. So think of alkalosis. Remember the use of insulin because insulin pushes the potassium back into the cell. And of course, the use of beta agonists such as albuterol. Remember, for hyperkalemia, albuterol can also be a treatment. Now, connect that low potassium back into the symptoms. When extracellular potassium falls, normal muscle contraction is impaired. That is why you can see findings involving the heart. You're going to see findings involving the GI tract. You're going to see findings involving the skeletal muscles. And when severe, it can also affect the respiratory muscles. The key is to connect each symptoms back to altered electrical activity and impaired muscle function. That is much more useful than memorizing a list of unrelated signs and symptoms. Now that you can recognize the cues and explain why they are happening, the next question you have in mind is which of these problems could harm the patient first, and what are you going to do about it? So one of the NCLEX next generation clinical judgment model, the next step is prioritizing the hypothesis. This is simply saying what are your priorities. So when you prioritize hypokalemia, your highest concerns are definitely dysrhythmia and severe muscle weakness. So start with the heart. Let's start there. Is the patient showing signs of dysrhythmia? Look at the pulse, the cardiac rhythm, and the overall cardiovascular status. Now, look at the severity of the muscle weakness. Is the patient simply weak, or has the weakness progressed enough that it's already affecting the breathing patterns of the patient or creating a safety problem? Then determine why the potassium is low. Remember, we talked about that, some of the causes, right? Is the patient losing potassium? Is the patient losing potassium? Has potassium shifted into the cell? Is there poor intake, or is the intake inadequate, or is dilution contributing to the low concentration? And do not look at potassium by itself. Check other electrolytes. Check whether magnesium is also low, whether the patient takes digoxin, or whether the renal function may affect how you manage the potassium. So once you identify the most concerning problems, so this is where the focus of this section is. Once you prioritize but hypokalemia and the problem, once you identify that and the likely causes, now you can generate solutions. That's the next step in the clinical judgment model. Now you can generate solutions that can actually match what is happening. Okay, so let's start with what we have. The first one, potassium may need to be replaced as prescribed. Okay, but replacing potassium alone is not enough if the patient is continuing to lose it. So the next step is addressing the cause, such as perhaps the GI or the gastrointestinal losses. Patient is vomiting, then let's treat vomiting, right? The patient is on NG suction, then let's monitor that very closely. Or a medication contributing to the potassium loss. Then monitor the patient. That's the most important thing. That's one of the nursing interventions that's a priority. Depending on the severity, that may include monitoring ECG, That may include blood pressure, that may include the pulse, that may include the muscle strength, and that may include monitoring bowel sounds. So when ECG is going to be monitored, these are the three things that you have to look for. So you're going to have a T wave that is going to be flat. This is for hypokalemia. And then you're going to have ST depression, okay? And then last but not the least, you're going to have what we call the prominent U wave in your ECG. So those are the things that you need to monitor. So another thing to remember, because hypokalemia can significantly affect muscle weakness, use fall precautions. This is very important. Again, this is like a priority. Use fall precautions when weakness is present. So think of your plan in two parts. The first part is, I'm going to write it down. We're going to correct the potassium, and then the other plan is to figure out the cause of hypokalemia and to treat the cause of hypokalemia. Now, we know what needs to be done. The next step is carrying out that plan safely, because potassium replacement itself can cause serious harm if it's not administered correctly. So let's take action, okay? That's the next step. If oral potassium is prescribed, so PO potassium is prescribed, it can be given with food or with fluids when allowed, because potassium, remember, can irritate the gastrointestinal tract. Now, if the potassium is going to be administered via the intravenous route, it must be diluted, and this is very, very important. It must be diluted and administered using an infusion pump. And here is a safety rule that you really need to know. Never give potassium IV push. Potassium is also not given intramuscularly or subcutaneously. So remember that. Never IV push, but it can also be given intramuscular or subcutaneously. Next, monitor the patient during replacement. Watch for the IV site, because remember, potassium can irritate the vein. So we need to look for that. Um, Monitor the ECG when indicated, assess renal function, and repeat potassium levels according to the treatment plan. If higher concentrations or more rapid potassium replacement are required, a central venous access or a central line may be used according to the prescribed regimen and facility policy. But administering potassium does not complete the nursing process. Now you have to ask, did the intervention work? That's why one of the clinical judgment in your NCLEX exam is going to be evaluating the outcomes. Did it work or did it not work? So by administering potassium, uh, we have to ask this question: is it working or is it not working? So let's start with the potassium level. You want to see the potassium trend back to the normal range. So like I said, most organizations are going to use 3.5 to 5.0. In some organizations, they may use a little different, but most of your textbook is going to use that, right? Now, reassess the patient. The pulse and the cardiac rhythm should become more stable. The blood pressure should remain appropriate, and muscle weakness should begin to improve. Then let's look at the gastrointestinal function. bowel sounds, and GI motility should begin to improve as muscle function recovers. If the patient ECG abnormalities related to hypokalemia, then look at those changes, see if it's resolving. So we need to really monitor that. Remember the symptoms that I mentioned earlier, right? For your ECG, remember I said flattened T wave, right? You're going to have ST depression, and you're going to have U waves. So when we see that it's improving, then you don't have any plateau T wave, meaning to say the T wave is now normal. There's no ST depression, and then there's no U waves anymore. And then finally, and this is very important because, like I said, potassium is an IV irritant. So evaluate the IV therapy itself. There should be no evidence of phlebitis or infiltration at the IV site. So remember the major safety point from this slide. Intravenous potassium should be diluted and administered using a controlled infusion pump. Never give potassium via intravenous pushes. Now let's take everything we just covered and put it into one picture. What caused the hypokalemia? Let's look at that. What the low potassium does, what cues you see, and what the nurse needs to do. This is what I call the overall picture of hypokalemia. So for all the things that we talk about, this is one of the slide that you really need to remember, right? Let's start from the left section over here. Sorry, just move that a little bit. Like section over here. So hypokalemia, right, can result from lost potassium shift into the cell, or inadequate intake. Think about diuretics. Think about GI losses in, right? Remember that GI losses such as vomiting, diarrhea, or continuous NG suctioning. And think about potassium shift into the cell in some scenarios such as alkalosis, the use of insulin, or the use of albuterol. Now, move to what happens when the potassium becomes low. So think about this. Think about this. If the potassium is below 3.5 milliequivalent per liter, that affects normal electrical activity and muscle function. That can increase cardiac irritability and reduce normal muscle function. And that leads us to the cues. It's very, very important. In the heart, you may see dysrhythmia. You may also see weak pulse. In the skeletal muscle, you may see weakness and cramps. In the GI tract or the gastrointestinal tract, you may see decreased muscle activity that can also produce constipation and, in a worst case scenario, ileus. And if the hypokalemia becomes severe enough to affect the respiratory muscles, the patient may develop shallow breathing. Now, bring that into your nursing priorities, right? Monitor the cardiac rhythm when indicated. It's very, very important. Replace potassium safely, identify and treat the cause, protect a weak patient from falls, so remember fall precautions, and evaluate potassium trend along the patient's clinical response. And here is an exam trap that I want to share with you all. Okay? Here's the exam trap. Do not treat hypokalemia just as a low lab value. Low potassium creates a body system pattern. We talked about all the issues that comes with it, right? Once you understand the connection between the cause, the low potassium level, the impaired electrical and muscle activity, and the symptoms, hypokalemia becomes much easier to work through an exam. Before you move on, answer this question. A patient with hypokalemia develops increasing muscle weakness and shallow respiration. Why is that more concerning than constipation? So, if you can explain the connection instead of just identifying the symptoms, then you understand hypokalemia rather than simply memorizing it. Watch this video over and over if you're still in nursing school. Save this and share this with your classmates and come back later.